from that. We've since gone on to do a study with parents to try and understand what was engaging them in the program and what were some of the barriers around that, particularly amongst more disadvantaged parents. So quick geography lesson. So Victoria is second smallest state in Australia. It's got about 6 million people. And just to put it in perspective, that's how Ireland would fit into Victoria. So even though it's our second smallest state, I think Ireland fits about 3 times into Victoria. So the infant program was being implemented in metropolitan Melbourne, but also in some of the more rural and regional areas of Victoria as well. So moving on to some of the results around the facilitators implementation. I think first up, really, in terms of the program being taken up, it was really that relationship that the researchers had with the policymakers in the health department. And I think this is one of the quotes to say that I think what the existing relationship did was give us the opportunity to get our foot in the door. We were considered a trusted source, experts in the field. So it's about co-production, the fact that researchers were working well with the policymakers right from the beginning. And also there was a small amount of funding made available for the researchers to be involved in the translation effort. So they're able to package up the research trial intervention and make it a program that people pick up and deliver. And the areas really liked the fact that they could have access to this prepackaged program, and it addressed an area of need. So there were very few kind of interventions in children under 2. So most of it started in settings, so childcare centres and schools. So it was sort of a bit of a gap in need. In terms of facilitators of implementation on the ground, I think what Healthy Together Victoria did was they funded some health promotion positions that enabled a kind of a coordinator or a champion to get the program up and running. As one of the implementers said, often you can have different people across different organisations, departments that are interested, but you need someone to kind of bring it all together, set it up. I think in terms of sustaining delivery of the program, the fact that it fitted well with existing delivery structures, so there were already first-time parent group going on in most of these areas, so it was able to slot quite nicely into that. As said by one of the policymakers, I mean, there's not going to be funding available to support and fund multiple programs. So it'll just be about how the program can be integrated with the system. So it was absolutely critical that the program had to be integrated with how things were currently working, because everyone knew this funding wasn't going to be available forever. And I think a really key facilitator of implementation was that people did adapt the program. So one of the key adaptations that they made was they no longer used dietitians to deliver the program because they were too expensive, too few and far between, and most of them chose to use maternal and child health nurses or parenting support workers. The other change that people made was that they found that after 12 months it was really difficult to get parents to come back, so they actually reduced it to a 4-session program over 12 months, and that was kind of the main changes that people made. As one of the managers said, you have to adapt it to what you've got capacity to run. We run it with maternal and child health nurses and parent support workers, which makes it much more cost effective. In terms of some of the barriers, I think for researchers, and I think this is a universal problem everywhere, is that there's quite a big turnover of policymakers, so it's very difficult to maintain that continuity of relationship, so there's a lot of effort involved in doing that. And I think this is probably an issue for researchers universally as well, is that translation is not traditionally rewarded in the same way that teaching and research is, so it's actually kind of a bit of a sideways step. And this is one of the lead researchers saying it's so much of an add-on to my core business, which is ironic, isn't it? When you think about the academic role of developing knowledge and capacity, when it comes to actually doing what we said we wanted to do, which was implemented, we really had very little capacity to do that. In terms of implementation barriers on the ground, I think once people started scaling it up across a number of suburbs, then it became difficult to think about, oh, how many maternal and child health nurses will we need? And will we still be able to see the same number of individual people if we're running this group program? So people started to think about the role and whether the role needed to change and shift a little bit. I think like most group programs, there's quite a heavy administrative burden around kind of setting up groups, so that had to be sort of absorbed into someone's administrative role somewhere. And I think a very interesting one was that it was a very kind of bottom-up approach, this prevention initiative, and areas were very much left to develop their own evaluation. But they came to us and said, we don't know what to evaluate, we don't know how to measure it. And so very little evaluation took place, which made it quite difficult for them to actually make a case for the program to continue. And I think a real balance for most of the areas was balancing this kind of need to adapt it to make it fit the local context, but then worrying about whether they'd changed the program too much that it wasn't going to work. And I think this quote really sums it up. You know, how do you have the guidelines that they're flexible enough that it's still infant, but not so flexible that the research is no longer relevant. I think that's a sweet spot that's really hard to hit. And I think the work with parents has told us that we need to be quite flexible in how we deliver programs. And I think anyone who's a parent in the room will know it's actually quite difficult when you've got a baby to try and be at a particular place at a particular time. And people were telling us we need kind of flexible models of delivery. As said by this mama, I think if you can have it available in other ways, online, as a resource for people who are finding it hard to get out of the house because last night was horrible, something like that I think would be fantastic. So we've really taken that on board, and we've gone ahead and developed an app which really incorporates a lot of the content and informed largely by the infant program, and we've done an initial feasibility study of this with parents. And what we found is that they really do like having this flexible delivery model of having an app and having the information available, and we're sort of using all the findings from the feasibility study to develop the next version of the app, which will start in pregnancy and go to the first 12 months of life. And I'd like to talk about what I call the bonus benefits of community implementation, and what I mean by that are some of the benefits that come out of implementation that you don't necessarily see in research trials. And I think facilitators were telling us that they spend a lot of time kind of connecting parents to local services, so whether that's the library or whether that's to maternal and child health services or the local swimming pool, and that didn't necessarily happen in the research trial when dietitians were coming in and delivering sessions. And practitioners delivering the program told us that it influenced what they did in their individual consultations with parents. So they were kind of taking what they learnt from the group, and they were then kind of implementing that, and the same kind of messages were coming through. And it really started to strengthen the partnerships between early years services, so preschools and childcare centres, because they were all kind of involved in setting the program up. And I think at the system level, it really raised the profile of prevention in the early years, and in particular kind of that you can start in infancy, you don't have to wait till kids get to childcare before you can intervene. And this is one of the coordinators who said, I think it's really put the lens on the early years and the importance of health promotion and really connecting up all the different players. So I think this probably comes back to the idea that programs that target individuals can influence this kind of broader system approach, that you can actually have both working together quite nicely. So some of the key lessons that we've distilled from this, and key lessons for researchers firstly, I think we do need to set up our partnerships with our end users right from the outset, not to wait till we've got research findings. Pre-packaged evidence-based programs are really highly valued by people on the ground. They don't want to reinvent the wheel, they want to have something that's got some evidence behind it. And I think as researchers we have to plan our interventions with the end in mind, so we need to make sure that they're going to fit existing delivery structures and that they can be scalable. There's no point having a wonderful intervention that's got no chance of ever being implemented in the real world. And also I think we need to report our research with the end in mind as well, so we need to report things around feasibility and acceptability and cost and workforce, and efficacy is incredibly important, but we do need to consider all these other aspects of external validity. And I think a key lesson for me was that program adaptation will occur. It's absolutely necessary for a program to be sustainable. And I think as researchers, the onus is on us to make it really clear what the core elements of the program are, so the logic model, the mechanisms, and say, well, don't mess with these, but you can mess with these bits. So you've got to make that quite clear. And that's easier said than done. I think key lessons for implementers and policy makers was having that local coordinating workforce certainly initially was important in getting the program up and running. But in terms of sustaining it, it really had to start to become embedded within existing service roles that were going to be there on an ongoing basis, and that was really dependent on having good partnerships. We need to build translation into existing research funding schemes so that the research doesn't end with the publication of a paper. And we have published this research for people who are more interested in the details of the findings. And just in terms of our next steps, we have got a great postdoc working with us looking at a sustainability study. So surprise, surprise, we had a change in government and the funding for that program has now ceased. So we're very interested to go back and actually find out of the areas of implementing the program, who's managed to continue it and why, and what are the sustainability factors. I think that's incredibly important. And as I've mentioned, we are doing a study with parents, and we're really interested to understand how we might tweak the program or look at other ways of delivering the same kind of messages so we get better engagement, particularly with our more disadvantaged families. So this work is really part of a broader program of work as part of a new Centre for Research Excellence in Australia called EPOC, and that's the Early Prevention of Obesity in Childhood. And this work is all part of Stream 4, which is all around translation of evidence into policy and practice. And that's a stream that I'm co-leading with a number of other people. We've also got 3 other streams, one around prospective and meta-analysis of intervention trials, and another stream around looking at developing brief evaluation tools, which would have been great to have in this program so they could have evaluated it a little bit better. And also a very important stream around health economics. So here's a wonderful group, and we've also got a website. And if you're interested in following some of the work, then please feel free to check out the website and sign up for the newsletters. Finally, I'd like to acknowledge the funding bodies and all the people that have been involved in the Infant program, in particular my mentor and close friend Karen Campbell, who is the lead investigator for Infant, and without her none of this work would have been possible. Thank you.